Design elements of randomized controlled trials. By the end of this presentation, you should understand common methods of randomization, know the main advantages and disadvantages of RCTs, be able to appraise how randomized controlled trials have been used for glaucoma research. In randomized controlled trials, we use the random allocation of subjects to ensure that the intervention and control groups are similar in all respects with the exception of the treatment or other intervention being tested. So what's randomization? Randomization is a method of randomly allocating participants into the experimental or control group, and each participant has equal chance of being in either group. This has the effect that it eliminates selection bias and also minimizes confounding by distributing both known and unknown factors equally into both arms. With good randomization, the treatment groups are similar in all respects apart from the intervention being investigated. All participants have exactly the same chance of allocation to the treatment or control group. In a well-designed RCT, it is important that allocation to a treatment group is determined by chance. It must not be predicted or influenced by either the investigators or participants. The actual randomization of each participant is best done off-site, especially not by the investigator. For example, an investigator might telephone a central office to find out which group to allocate a participant, although nowadays it is more common to be done on a computer. There are different methods of randomization. It is very important to note here that allocating participants to treatment groups by date of birth or by day of arrival at the clinic is not random, and these methods should not be used. Simple randomization. The simplest method of randomization is tossing a coin. Simple randomization is rarely used because, by chance, you can get an imbalance in the numbers assigned to each arm. Block randomization is used to ensure that the number of participants assigned to each group is equally distributed. This method is commonly used in smaller trials. Stratified randomization is used to ensure that any potential confounding factors are more evenly distributed between groups than may happen by chance alone. For example, participants may be stratified by age or by location. There are a limited number of factors that can be balanced by stratification. This is because of the potential for small numbers of subjects within each stratum. If a trial is taking part in different clinics, stratification is always by clinic. Minimized randomization. This method can be used when the study is small and simple randomization will not result in balanced groups. The key design elements in RCTs are baseline data, follow-up, assessment of outcomes, analysis, interpretation. Nowadays, there are strict rules that have to be adhered to when carrying out a randomized controlled trial. All RCTs must have an Independent Data Monitoring Committee, or IDMC, which reviews the study data at predetermined regular time points during the trial. This committee monitors the trial outcomes and any adverse events relating to the intervention. RCTs use standard operating procedures, known as SOPs, to document and explain every step of the study. Baseline data are collected, both demographic and clinical. Participants are followed up at regular intervals, depending on the condition being studied, and follow-up data are collected. Investigators assess the study outcomes at each follow-up visit. What are the advantages and disadvantages of randomized controlled trials? Advantages. Randomization eliminates selection bias as the participant is not allocated to the intervention or control group by the researcher. Randomization tends to create groups that are comparable for all factors, both known and unknown, that may influence the outcome. This eliminates unknown confounders which, because they are unknown, are impossible to measure. Any baseline differences that exist between the trial groups are attributable to chance rather than bias. Disadvantages. Unfortunately, randomization does not guarantee comparable groups, as differences between the arms may arise by chance. How have randomized controlled trials been used for glaucoma research? Previously, glaucoma was regarded exclusively as a consequence of abnormally high intraocular pressure. Many prevalence studies have shown that across many populations, intraocular pressure was within normal ranges in patients with glaucomatous optic neuropathy. The relationship between intraocular pressure and glaucoma was not clear, which was an obstacle to clinical decision-making and posed many questions about the influence of pressure-lowering drugs. Investigators decided to address the problem by carrying out randomized clinical trials to understand disease progression, as visual field loss, better. They compared pressure-lowering treatment versus no treatment. We're going to look at the UK glaucoma retreatment study randomized controlled trial to illustrate this study design. This was a randomized triple-blind or triple-masked placebo-controlled trial. Triple-blind means that the participants, clinicians and those that assessed the primary outcome did not know to which arm a participant was allocated. This was not difficult to do, as the eye drops and placebo used in the trial were labelled at manufacture only with the study ID of the participant. Otherwise, the two types of drops looked identical. The RCT was multi-centre and carried out at 10 different UK centres. Participants in the intervention arm received latanoprost 0.005% eye drops. Those in the control arm received placebo eye drops. All the participants put drops in both eyes once a day. Participants were patients with newly diagnosed open-angle glaucoma. Random allocation was by a website-generated randomization schedule and stratified by centre. Stratification by centre meant that there were equal numbers of intervention and control participants in each centre. The primary outcome was the time taken to visual field deterioration up to the 24 months. The data were analysed by time to event, where the event was confirmed visual field deterioration. Events were compared between the two groups. This produced a hazard ratio. A hazard ratio of less than 1 means that the risk of progression is lower in the intervention group. A hazard ratio greater than 1 means that the risk of progression is higher in the intervention group. The strengths of the UK glaucoma treatment study are: there was no previous trial of the relationship between intraocular pressure and development of glaucoma, using newly diagnosed, previously untreated participants. Treatment allocation was concealed. There was no current best treatment, so placebo could be used. In summary, randomization ensures that each participant has an equal chance of allocation to either group, eliminates selection bias, balances the groups for known and unknown confounders. The RCT provides the strongest study design to provide evidence on effectiveness and safety of an intervention.